Good afternoon. Thank you for having me. My name is Katrine, and I'm a resident in emergency medicine at Hørsholm Regional Hospital in Denmark. And I just recently finished my Master of Disaster Management at Copenhagen University. My master's thesis looked at disaster preparedness amongst doctors and their training, and I'm really excited to show you a little bit about the findings. My medical career began at the end of 2019, and before long I was part of a global pandemic. And while running around like a headless chicken, as we all do as new clinicians, I was also trying to navigate decontamination areas, security zones, and ever-changing treatment strategies. I quickly realized I was part of a frontline disaster response, but felt that neither my studies nor my department had prepared me for this. And I started asking myself whether it was just me or if others felt the same. So we'll start with a short exercise, imitating a little bit the research I did myself. I'll prompt with some statements, and I want you to raise your hands if this statement fits you. I feel responsible to act in a disaster setting. Great, okay, thanks. I feel prepared to act in a disaster. Okay, some of you feel prepared. Okay, cool. And I would like more disaster training. Okay, great. Okay, so at least many of you feel the same as the participants in my research, which is kind of nice. If there's one thing I want you to take home from today, is that Danish doctors feel highly responsible to act, but feel insufficiently prepared and want more training. Improving our common and their disaster preparedness should be a priority and requires informed, standardized, and recurrent training. In short, the research objectives of my thesis were to look into how we could improve disaster preparedness. This was done in two ways. First, explore the perceived disaster preparedness and training of Danish doctors through a cross-sectional survey research. Secondly, by identifying the strengths and weaknesses of different training approaches towards doctors. This together informed an evidence-based recommendation in how to improve disaster readiness. Today, I only have time for the cross-sectional review research findings, but if you have any questions concerning training or anything else, ask me or grab me for coffee later. Good. In short, we'll look a little bit at the theory of disaster. I'm not going to go too deep into that, but then going to the cross-sectional survey, discuss and conclude. The theoretical frameworks behind my research is first and foremost a common understanding of what is a disaster. We have all tried different crises in our lives or at the front line, and here I use the United Nations Office of Disaster Risk Reduction definition. That is a serious disruption of the functioning of a community or a society involving widespread human, material, economic, or environmental losses or impacts, which exceeds the ability of the affected community or society to cope using its own resources. This creates a foundation into what is a disaster risk, and I base mine on Ben Visner's work, where disaster risk happens at the intersection of a hazard, exposure, and vulnerability of a community. In understanding it so, disaster reflects a cycle of processes that overlaps, which is important to note. And my research focused on disaster preparedness as a thing, which is the development of systems that strengthen both organizational and individual readiness to minimize the impacts of disasters. That is where I believe the critical care competences come in and come at play in our field. When examining the global trends on disaster preparedness amongst healthcare workers, there's the same claim comes over and over again, is that the healthcare workers feel highly responsible, but do not feel knowledgeable or confident in their role and want better disaster training. What I find is that, or I found that there was a lack of data from Denmark. So that's where we look into the cross-sectional questionnaire study. How do Danish doctors perceive their disaster preparedness and training thereof. An online questionnaire was created in Google Forms with 26 different questions looking at demographics, knowledge, and attitudes towards disaster medicine and disaster risk management. There was a mix of yes and no answers, Likert skills, from least to most, and then open-ended answer questions. Participants were doctors in Denmark, working in Denmark, with an emergency function. As we might have looked a little bit at the panel debate, in Denmark we have a lot of different strategies depending on the emergency department. Some are ran entirely by emergency medicine, or not entirely, but tried to entirely by emergency specialists. Others are more hybrid, where we have a lot of surgical and medical internists in the staff. The distribution of the survey was done through social media and mailing department lists. And finally, all data was analyzed with SPSS, mostly descriptive, statistic, a little bit of comparative. Good. So the main findings, I can't get into all the 26 questions, but what I find most interesting here was that I had 151 participants from 21 different specialties, mainly emergency medicine, internal medicine, and general surgery. There were participants from 26 hospitals, meaning we noted from earlier that we have 21 emergency departments, but a couple more hospitals, and some of the participants still see their function as emergency-like. I had answers from 4 different training levels, so from the interns, the trainee in specialties, and attendings. I excluded the consultants, which you would know as overlæger in Danish or overlæge in Swedish. And what I found was 61.6% had never received any sort of training. There was no difference across training levels and specialties, but those who did receive some mentioned lectures, online modules, and a few had simulations and tabletop exercises. That's more than half of the participants that hadn't had any sort of training. 74% wanted more training. Very humbly, most of them asked for simple orientation into contingency plans, whereas others were more ambitious and wanted greater recurrent, blended workshops. When I examined then their perceived knowledge on a Likert scale from 1 to 6, where 1 is lowest and 6 is the highest, the mean score were lowest for the CBRN management, so the chemical, biological, radiological, nuclear, and explosive events. They were very low for the MCI, so the mass casualty incidents, and low for patient evacuation. Meanwhile, the scores had a mean score that was moderate for triage, which sort of suggests that this thing that we do every day routinely is better integrated amongst participants. So poor knowledge. Oh, and finally, as well, very important, there was no statistical significance between the training levels. So from the youngest of doctors to the oldest of doctors, more experienced, they all felt low in their knowledge. When examining their perceived previous training, I found that the mean scores were low for both university education in disaster risk management, disaster medicine, but also at a departmental level. Again, this had no statistical difference between the training levels. So from the youngest to the most experienced, none of us really felt that we had had any training at the university level or departmental level. Today in Denmark, there is no official curriculum in disaster medicine. Lastly, when examining the disaster attitudes, there was a high sense of responsibility, a high expectation of future involvement, talking into the geopolitical climate and the coronavirus we were all part of, and a moderate sense of readiness. Here, there was a statistical difference in the sense of responsibility. Our trainees felt more responsible than the attendings. Maybe talking into a pic, not that the attendings are not feeling responsible, but that the frontline, who doesn't have the experience, who doesn't have the training, feel a higher sense of responsibility to be able to do the work. So, in summary, Danish doctors feel moderately prepared They have a high expectation of involvement and want more knowledge and training. So, such research presents various limitations. I've marked some of them here, but most importantly, for me, a cross-sectional design captures only a self-assessment point in time, which means that there's no evaluation objectively neither to their competences, the organizational competences, or their psychological resilience. It is important to mark that preparedness is not just about hands-on skills in an operating room or in the ED. It is also about the organization, but also the willingness to risk. So, my research prompted many discussion points. I've chosen 3 of them. The first is I find there's a system-level gap, at least in Denmark. National authorities warrant both hospitals and departments to prepare, but not necessarily having any plan, informed plan, funding, or responsibility delegation. If national disaster resilience at our frontline is a priority, especially during the geopolitical climate, how do we coordinate responsibility, funding, and planning? Secondly, measuring is complex. Today, the current tools when looking into disaster preparedness is highly self-assessment. You're likely to use self-assessment tools rather than observational evaluations. And how do we then train or design training that can encompass all aspects of preparedness when we don't know what the real preparedness is? Lastly, designing training is complex. First of all, the research on medical education is methodologically weak. I could go in 2 hours about why it is. But the question still becomes, if we wait for the perfect data or the perfect research, will we ever get to the readiness of our frontline? So in summary, Danish doctors feel highly responsible, want training to prepare for the worst. The evidence supports prioritizing better disaster assessments, but also better research into medical education in general. However, this should not halter the development of neither training, design, or implementation. Future research should focus on better or more comprehensive disaster assessments and stronger evidence-based research on medical education in general. I'll leave you with this citation from one of the associate professors at Copenhagen University. I think also Churchill was named for this one, so it's not something new. But if you fail to prepare, you prepare to fail. Thank you. Oh.
So thank you very much, Katrine. Do we have one quick question, possibly 2? Yep. 1 second. And could you please also state where you come from?
My name is Halfdan. I'm from the emergency department at Hørsholm Regional Hospital in Denmark. And I have one question for you. Thank you for pointing out a problem. How do you create this education for all of us? Next step.
Oh, that's a great question. I have reflected on this question many times, and I have to admit, Halfdan, that I don't have the proper answer. What I do see is that what people ask for and what the scoping review showed was that training, we shouldn't be afraid to fail when trying to implement training. So whether it's I can't say if it should be a local issue or a departmental issue or a national issue, but most importantly, putting down a group that would like to do better education, whoever the stakeholders may be, look at any stakeholders, especially those in residency or in specialty training, ask them what they want, what they could want, and then try out, fail, evaluate, try out, fail, and evaluate. Where we start, I don't know.
Thank you very much for that, Katrine. I think in the interest of time that we'll move on to Anna now, and we'll save further questions for the coffee break. Yeah. Thank you very much.